evening, friends. I welcome all of you on this milestone, the mammoth 100th webinar of Inches Academy with IDG. And we have none other than my dear friend, my colleague, we did MBBS together, Dr. Suhas Prabhu, who had also done our 50th webinar. Suhas, welcome.
Thank you.
I hope you received the cake and the bouquet.
Yes, I have it.
So I think please cut the cake and then start the talk.
Oh, you want the cake to be cut first or at the end?
We can cut at the end also, no issue.
Chalo, cake to yahi hai. Aap bola to, am I allowed to eat it also first?
So Dr. Suhas Prabhu needs no introduction. In our college days, he was gold medalist all throughout. He's been getting medals all over, and he is a wonderful teacher and a wonderful pediatrician, a consultant at Hinduja Hospital. I know there are several of you here who have attended each and every of these 100 webinars. And I thank you all for motivating us by giving us good inputs. So without wasting much time, that is a tradition of Inches Academy, I hand over to Dr. Suhas Prabhu to regale us with his wonderful knowledge on the topic of rational use of antibiotics in children. Suhas, over to you.
Thank you, Chandu. Pleasure to be here today. And I believe this is my third or fourth session with Inches and IDG.
Yes.
Always a pleasure to talk to a very receptive audience. And I must congratulate you before I start for 2 points. One is, of course, the 100th seminar. Centuries are hard to come by. Ask Virat Kohli. Centuries aajkal hote nahi hai. So it's really creditable that you have reached 100.
Thank you very much.
Pray that you get a double century and a triple century and so on in the years to come.
Thank you very much. Thank you.
That's the first reason to congratulate you. The second reason to congratulate you is the fact that the topic you have chosen for the centenary is such a vital topic. I can't think of a better topic that you could have chosen. I will be touching upon the issues of rational antibiotic practice in my talk. But before I start only, I want to state that this is one of the most important pressing problems that we are going to see, we are already seeing today, we're going to see more of in the future. If we do not use antibiotics rationally, we're going to be in serious trouble. So with that small introduction and with Dr. Asrani's permission that I will cut the cake later, I will go to my presentation.
I would like to just take 1 minute. You remember Dr. V.R. Joshi?
Yes, of course.
Once when he was talking in a seminar, he literally had tears in his eyes on how doctors are abusing antibiotics and creating massive antibiotic resistance. I worship that man, and then I think whatever we can do in our lifetime to use antibiotics rationally, people even use in their own family members without thinking. So, Suhas, I think your talk will be most welcome by our audience. Please take over.
Thank you, Chandu. Can all of you see my slides? Hello?
Yes, we can see.
Okay, fine.
Yeah.
So the topic that Chandu has asked me to speak on is rational use of antibiotics in children. And I am aware that this is part of a series of 4 sessions. And he told me that he was to speak last Thursday. I did not tune in, on the basics of antibiotic spectrums and bacterial pathogens and what antibiotics normally work for various bugs or pathogens. So I'm grateful to him for laying the basis so that I'm not really going to touch upon those except where it really actually concerns the clinical situations in children, but I will not go into the theory. I believe Dr. Chandu has covered that. So what am I going to talk on today? I'm going to start with the relationship that antibiotics have with infectious diseases, that too the bacterial ones primarily. I'm going to talk about the main thing, the reason why, the raison d'etre why today's talk is important is the increasing antibiotic resistance that we are all encountering, and therefore the need to use antibiotics rationally. And then, of course, I'm going to talk to you about antibiotic choices in common pediatric infections. I'm going to stick to pediatric infections because I do believe Dr. Soman is going to speak next Thursday. He will probably cover what antibiotics you would use for adult infections. And as you can see, I've put here, I will be primarily talking about treatment of outpatient bacterial infections. And obviously it's going to be bacterial infections because we all know that antibiotics do not work for viruses. However, I need to specify that when you use the term antimicrobial, you encompass not only antibiotics, but also antifungals, antivirals, antiparasitic agents, and in fact, anything that is potentially a pathogen. But when you use the word antibiotic, you are primarily referring to bacterial infections, and that's what I'm going to stick at today. So I'm going to cover only the common outpatient bacterial pediatric infections that you're going to see, not the ones that are going to require hospitalization and parenteral or inpatient care. And lastly, what do we need to do when we have noticed this increasing antibiotic resistance and the fact that we need to use antibiotics rationally? I'm going to leave you with some messages which are quite dear to my heart. And of course, as Dr. Asrani said, were very dear to Dr. V.R. Joshi's heart. He is still around. I do meet him occasionally. He's of course become very old and frail. But as Dr. Asrani said, a man I respect tremendously. And like him, I also respect him tremendously. So with these few words, let's talk about the relationship between infectious disease and antibiotics. Now, we know that infectious disease, Hans Zinser said this, is a tragedy of living things. Because remember, the bacteria also are alive. Evolution wants them to survive. But humans are another form of life. And when the bacteria invade us, they tend to kill us or destroy us or damage us. And therefore, we strive back again. So this is a struggle. It's a war for existence between two different forms of life. And in this war between two different species, a prime weapon that we have against bacterial pathogens is, of course, antibiotics. It all started, as you all know, with the serendipitous discovery by Sir Alexander Fleming on the 28th of September, 1928, where he saw this fungus, this yellowish fungus growing on a mold, this greenish fungus growing on a mold, on a Petri dish, which he had inadvertently left open when he closed the lab the previous night. Sheer chance that this Penicillium notatum fungus spore happened to fall onto that plate, and he was able to see that this fungus was growing on that level. And from this, he isolated the chemical penicillin. And within a few decades, we got a cascade of new weapons that we learned to play with. And I'm using the word play because we have literally abused them, as Dr. Chandu used that word. That's absolutely right. We just played around with antibiotics, not respecting them as much as we should. So we know that even before penicillin was detected in 1928, sulfonamides were detected pretty earlier. And even before that, we had the silver bullet salvarsan, which was used for syphilis. That was, of course, not an antibiotic in the sense that it was not made by another living organism. It was a chemical agent, what is called as chemotherapeutic agent. So sulfonamides, chemotherapeutic agents, 1930s. Then we had the penicillins, which belonged to a group of beta-lactams. Although it was discovered in 1928, it was only in the 1940s that we were prepared in large enough numbers that we were able to use them. Streptomycin was the first aminoglycoside discovered in 1944. And we had these groups, 4 groups of antibiotics in the 1950s, chloramphenicol, tetracycline, macrolides, glycopeptides, of which the most famous one, of course, is vancomycin. Then the streptogamins, quinolones and lincosamides in the 1960s and 70s, trimethoprim to add on to sulfonamide came in 1970s and so on. So we had a lot of antibiotics by the time I graduated from my postgraduate course in 1979. So much so that the United States Surgeon General spoke to the US Congress in 1977, and in his speech he said, it's time to close the book on infectious diseases. We have so many antibiotics, we can kill all the bugs. We don't have to worry about infectious disease at all. What hubris, what supreme overconfidence. He forgot that even Sir Alexander Fleming himself, in an interview he gave in 1945, this was in fact the year when he was awarded the Nobel Prize, and at that time he was interviewed by the New York Times, and he warned that the misuse of penicillin could lead to propagation of mutant forms of bacteria that would resist this new miracle drug. And even before that, Paul Ehrlich, the discoverer of salvarsan, which I referred to earlier, said that drug resistance follows the drug like a faithful shadow. Two important warning messages given much earlier, we did not heed them. And what did we find? We found that within a few years of discovery of an antibiotic, we found that resistance was happening. Look at the blue marks here, 1928, the blue circle is the penicillin. By 1940, the first case of penicillin resistance was identified. Tetracycline discovered in the 1945 or 46. By 1953, within 8 years, the bugs are smarter than us. They learned how to combat or resist this antibiotic. Macrolide discovered in 48. By 1980, we had resistance. Fluoroquinolones were when they came, they were the wonder drugs. But within 1 decade, fluoroquinolones have lost their shine. When they came in 1989, I believe in India, ciprofloxacin was the first fluoroquinolone marketed by, I believe it was Cipla. Within 10 years, ciprofloxacin is now a drug that has got so much resistance that we would hesitate to use it. As you can see, this is practically the shortest interval between discovery and resistance, almost at the same time. Even carbapenems discovered as late as 1985, within a decade, we are seeing resistance. So within a few years, the bacteria become smart enough to develop resistance to the antibiotic. And therefore, the world and clinicians have woken up to the danger posed by resistant microbes. And it's even come in the public press, like you see in the Times of India, this heading here saying that drug resistance is among our top threat. WHO has put drug resistance as the top 10, within the top 10 threats to human health. Not cancer, not HIV, drug resistance. I'll show you why. And in fact, the United Nations General Assembly, not the WHO, the United Nations General Assembly had an entire session on the threat of antimicrobial resistance to humankind. And it is only in the 4th time in the history of the UN that a health topic was discussed in the General Assembly. So see how important it is. Otherwise, you know what they discuss. They discuss war in Ukraine and other stuff. But they thought it's so important to discuss antimicrobial resistance because it is as much as a threat to mankind as possibly nuclear war. So if we look at what this WHO report says, it says that it's a serious threat to public health globally. What is the result of this? Infections are getting harder to control. Illnesses and hospital stays are getting prolonged. It's taking longer to get well from an infection, which of course entails an increased economic and social cost. And of course, the possibility that you might not fight the infection and die. So the risk of infection is getting greater. How much greater? Look at this now. What would be the number of people who would die from antimicrobial resistance, say in 30 years from now? We look at the blue bars now. The blue bars are talking about the number of deaths that you see from various diseases now. From antimicrobial resistance, even now, it is 700,000, 7 lakh people die every year from antimicrobial resistance. Compare that to road traffic accidents, 1.2 million. Tetanus, only 60,000. We should be worrying more about AMR than tetanus. Diarrheal disease, just about double that amount. Measles, 130,000. It's probably going down now. This was about 8 years ago. Cholera, 100,000. Diabetes, 1.5 million. Cancer, 8 million. So you may say, okay, it's still not too bad. But you look at the projection, by 2050, it is estimated that AMR, or antimicrobial resistance infections, will kill 10 million people every year, which is more than the number of cancer deaths per year, and practically the same amount as people who died in the Second World War. So it's huge. It's a major threat to mankind. So then you say, okay, it's fine. Why should I worry? I'll just wait for one new antibiotic to come along, and then we'll start this whole cycle all over again. I'm sorry. You're going to be disappointed, because the antibiotic pipeline is drying up. While we had a lot of antibiotics discovered within the first, say, 50 or 60 years after Sir Alexander Fleming discovered penicillin, the pipeline, you can see, is drying up. The number of new antibiotics discovered is steadily going down in every 4-year period that is listed here. Hardly any have been discovered in the last 10 years too. And companies that are researching antibiotics are only 4, compared to 18 that were doing this study in 20 or 30 years ago. Why is it happening that even drug companies don't want to do research to find new antibiotics? And it's a fact that the pharma industry has reduced its research efforts in infections because the return on investments is lower for antimicrobials. We have seen why. Because an antimicrobial which is so difficult to do research on and produce, within 10 years or 20 years becomes useless. No drug company wants to spend money to research on a product that is going to be useless within 20 years of being launched. Also, the fact that we know that researching a new drug is horrendously expensive. The figures are here, but I mean, I'm sure it's much more than this now. And it's a long process to make a new antibiotic. You can't discover it within a year. And it takes up to 15 years from the point of starting the research to putting it in the market. And in the last 15 years, we've had 9 new antibiotic agents, but actually some of them are just tweaked a little bit. Or you have a new combination of a beta-lactam with a beta-lactam inhibitor. They're not really new. Only 2, as is put on this slide, have offered a different or a novel mechanism of action. And if you look at all the list of molecular entities that are in development, and I think you know that companies are supposed to report on what molecules, without of course disclosing the details, what molecules they're doing research on. Of the 7 largest biotechnical firms, of all that they have listed, only 1 is possibly an antibiotic agent. So we are not going to get more antibiotics that we can squander the ones that we have. We need to hoard. We need to use very carefully our existing antibiotics. We need to save them. We need to protect them. And I think this 2 hands protecting something very precious is a very eloquent way of putting the fact that how we should be looking at antibiotics. It's like how you shade a lamp, an oil lamp, from the breeze. It can go out at any minute and leave you in darkness. This is almost as bad. And there was a nice paper, those who are interested can read how society and medical faculty in particular have failed to protect our precious resource in antibiotics. This appeared in the Lancet more than a decade ago. Now, what has caused this problem? Dr. Donald Lau says that the primary cause for the emergence and spread of antibiotic resistance is the inappropriate use of antibiotics. Because the important question is, how does an antibiotic overuse, misuse lead to drug resistance? And I'll try to show you in a small diagram. This is a very, very simplified diagram of how antibiotics induce resistance. We look at this, for example, these are 4 panels here in chronological order. You have a number of germs here in probably causing infection in a patient. And of course, by natural mutation, you will find an occasional organism that is drug resistant. Now, the ones that are sensitive are represented here by the light blue or gray color, and the resistant ones are represented by this pinkish, purplish mauve color. Now, when you treat a person with antibiotics, then it kills not only these organisms that are the pathogen, but also the good bacteria that are there in your intestine that are actually meant to protect you from infection. But what is left out are the drug-resistant organisms, which now multiply and grow, and they take over, and they result in a drug-resistant infection, which becomes then very difficult to treat. Not only that, bacteria have the ability to transfer this knowledge. And of course, what is this knowledge? It's actually a gene. It's a gene that promotes or provides the bacteria with the ability to combat the antibiotic. The mechanisms are complicated. I won't go into that. There is an efflux mechanism. There is a changing of the receptors on this surface of the bacterium, and so on. Whatever. The mechanism is not important. But once this is there coded in the gene, bacteria very willingly transfer these genes onto other bacteria. So what happens is that the drug-resistant bacteria transfer these genes onto bacteria that are otherwise not able to combat the antibiotic. And therefore, these also start becoming drug-resistant. So you can see how this disaster happens. And the more antibiotic you use, the more this is going to happen. There are enough epidemiological studies to show a direct relationship between the amount of antibiotic consumption and the emergence and dissemination of resistant bacteria strains. And look at the use of antibiotics in our country. This is a chart of the total amount of antibiotics used in our country. This is actually DDD, which is daily drug doses of an antibiotic per 1,000 population. You can see that on the left. And various antibiotics are here. The blue is trimethoprim, the orange are the macrolides, the light blue are the broad spectrum penicillins. These are the fluoroquinolones, and the green ones are the cephalosporins. And you can see that for some of these antibiotics, like the fluoroquinolones, broad spectrum penicillins, not the fluoroquinolones, sorry, you can see the fluoroquinolones use has declined because, as I told you, now we are seeing a lot of drug resistance. But you look at the broad spectrum penicillins and the cephalosporins, and their usage has increased 2 to 4-fold. Now, I am not sure that bacterial infections in this country have gone up 2 to 4-fold. So what does it mean? It means we are overusing and misusing antibiotics. So it's no wonder that we are going to see increasing antimicrobial resistance. The other thing that I see very commonly is combining two antibiotics. And I'm going to cover this first because I think it's very important. Because normally speaking, combining two antibiotics is irrational, especially if they are meant to cover two different organisms. Now, I think Dr. Asrani spoke to you last week about an antibiotic that say covers a gram-positive organisms, an antibiotic that covers a gram-negative organism. Now, if you use an antibiotic that is effective against gram-positive organism and one that works against a gram-negative organism, to the same patient who comes to you with sore throat or fever, then you are definitely irrational. This is something we call polytherapy. That means you are not willing to even think. You are too lazy to think, or you're just not bothered to think as to what is the possible organism. ये भी दे देंगे, वो भी दे देंगे, कुछ ना कुछ तुक्का लग जाएगा. Absolutely irrational. I don't think we can do this. We cannot afford to do this. And just because, you look at the second point on this slide, just because they are effective for the same organism does not mean that they will work better when combined. For example, let me give you have typhoid fever. We know that ceftriaxone or a third generation cephalosporin like cefixime works for typhoid fever. So does, for example, azithromycin. So that does not mean that, oh, I'm rational, I'm using both for typhoid. No, there is no evidence that using both together will make your patient better, faster, or more likely to recover than using one alone. So combination doesn't work just because it is both are acting on the same organism. So are we saying, am I saying that you never use a combination of antibiotics? You use, and there are occasions when you use it. I can give you examples. Rational only if multi-drug therapy is meant to act against different phases of the pathogen or different metabolic phases of the pathogen. One classic example is cotrimoxazole. We know that cotrimoxazole is a combination of a sulfonamide and trimethoprim. And I won't go into the details, but the site of action is the formation of tetrahydrofolate, which occurs in two steps. The first step is formation of dihydrofolate, and then the second step is formation of tetrahydrofolate. So the sulfadoxine or the whichever sulfa drug is combined with trimethoprim acts against the first step, and trimethoprim acts on the second step. So here, of course, it is rational because they are acting on the same pathogen, but at different phases or different sites or different mechanisms. The other place where a combination antibiotic is useful is when you want to prevent development of resistance. Now, this, of course, does not work everywhere. You cannot argue that I have a patient with sore throat. I think it is streptococcus. I know that ampicillin will work, but I want to add a cephalosporin just to prevent development of resistance to cephalosporin or ampicillin. No, I'm sorry, it doesn't work that way. Development of resistance and use of multiple antibiotics for the same is effective and recommended only in a few number of cases. And the conditions for doing so are actually two, and you have to satisfy both, and then only you can use multiple antibiotics to treat that particular infection. The first condition is the load of the organism in the patient at the time of diagnosis, that is the number of organisms that are already present when you make the diagnosis, has to be very high. It has to be in trillions, literally. Now, where are the situations where we have this? Not typhoid, not sore throat. One is tuberculosis. The second is, of course, HIV. The third is falciparum malaria. These are three common conditions you all know where we use combination of antibiotics. But of course, in case of HIV, it's combination of antimicrobials because we know that HIV is caused by a virus and not a bacteria. So that's the first situation where you must have a high load of organism to start with before you start to antibiotics. And the second, which is equally important, is use of these antibiotics is going to be for a long period of time. If you're going to use for 2 or 3 days or a short period, then combination is not justified. But we know that, for example, in tuberculosis, we use 6 months, 9 months. For MDR-TB, we use even longer periods. And in HIV, several years and sometimes lifelong treatment. So obviously, we're going to use these drugs for a long period of time. And therefore, there we are justified in using multi-drug therapy. But I would believe that any patient who comes to your outpatient, I'm not talking about inpatient, outpatient should never, 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 never receive 2 antibiotics on the same day. I don't think I can be more emphatic than this. We have no business to write 2 antibiotic prescription for an outpatient unless you are treating, of course, HIV and tuberculosis. You do treat them on outpatient, but I do believe that most family physicians would not like to treat these kind of cases and refer them to a specialist. Unfortunately, we use irrational combination by default because the company makes a combination and puts it in the market. And more than 2/3 of the formulations that are there in the Indian market are not approved by most drug controllers in the world. They are available. They are sold in India. You can buy it at the chemist. You can buy cefixime with azithromycin in 1 tablet, ornidazole with ofloxacin in 1 syrup, Metronidazole with norfloxacin in one syrup and cefixime with ofloxacin in one tablet. Absolutely irrational. We're the only country in the world where such combinations are marketed. 2/3 of all such combinations in the world are in India. I would say shame on all Indian pharmas who make such combinations. And shame on the Director General, Drug Controller General of India for allowing this to be marketed. And more shame on all clinicians who prescribe them. Anybody who writes this in his outpatient practice is either just not bothered, is too lazy to think, or he just doesn't know anything about antibiotics, leave-alone infections. I'm sure none of you qualify in this category, and therefore I do not expect that you would be writing any such combination ever, ever, ever. So having covered that part about general problems in rational antimicrobial resistance, and then I'm going to talk about antibiotic use in common pediatric conditions. Let's say if you have to be rational, what are the antibiotics that you would like to use, or I would like you to use, or I would suggest you use? And I'm going to cover only 5 conditions, which are, I would think this would cover more than 95% of the pediatric cases who come to you in your practice for outpatients. Upper respiratory tract infections, GI infections, skin and soft tissue infections, urinary tract infections, and possibly enteric fever. So I'm going to cover only these 5. Let's start with the URTI. When to start antibiotics and which one? Now, before I jump into this, don't expect an easy answer, because URTI is not a diagnosis. URTI is a conglomeration of conditions which are of varying etiologies. And therefore, you cannot lump all URTIs together and recommend one antibiotic for all. So what do we need to do? We need to make a specific diagnosis. Never write URTI as a diagnosis. It is paucity of thought or laziness of your mind if you write URTI as a diagnosis. You have to make a specific diagnosis. So what does URTI include? It includes a variety of clinical syndromes. It includes rhinitis, which you also refer to as coryza, which is infection of your nasopharyngeal cavity. Pharyngitis and tonsillitis, which refers to your oropharyngeal cavity, infection there. Cru, which is infection of your larynx. Epiglottitis, which is infection of the epiglottis. Of course, below the larynx, it's lower respiratory tract, so I'm not going to cover. Then we, of course, have extensions from the upper respiratory tract, that is otitis media, and from there on to the mastoids. So that is otitis media or mastoiditis. And then, of course, infection of the paranasal sinuses, which we refer to as sinusitis. So these are, so we should always write what is our diagnosis, one of these 6, rather than just write URTI. Now you see 2 of these are put in red. Why are they put in red? Because they're always viral. And when they are viral, you do not need antibiotics. So when you write down a diagnosis of coryza, you cannot write an antibiotic. When you write down a diagnosis of cru, you should not ever write an antibiotic. These are inherently viral conditions where antibiotics are not indicated. But let's come to those which are not in red. Let's start. Okay. Are antibiotics required for all URTIs? No. Even those which are listed as pharyngitis or otitis media, they're not necessarily bacterial. A vast majority of URTIs, at least those that you will see in the outpatient, are viral. They don't need any antibiotics. And in fact, many of the so-called URTIs, which we often diagnose on the phone because the parent comes and says, or talks on the phone and says, "Bachcho ko sardi khansi hai." You say, "Oh, give him an antibiotic." These may not be infections at all. This can be an allergic rhinitis. So common in our city with all the dust and the pollution and the change of weather. So all cough, cold, and sneezing may not be an infection at all, and therefore doesn't require an antibiotic at all. And often recurrent URTI is simply an exacerbation of a minor viral infection by allergic diathesis. A person who's got an allergic rhinitis or an hyperreactive airway often will have a prolonged cough and cold following a minor viral URTI. And just because it has gone on for a week or 2 weeks, we start thinking it is bacterial and prescribe an antibiotic. It's not correct. First, make sure that it's not an allergic diathesis, it's not a hyperreactive airway, and that is the one that is causing the cough and cold to go on. And remember, allergic conditions generally will not have any fever along with that. So the first thing before you even write an antibiotic is to document fever. If there is no fever, there is no basis for an antibiotic. There are very few conditions clinically where we prescribe an antibiotic as a treatment, not as a preventive, for an infection. And I will leave you to think that it's not really related to today's topic, but I can answer that question at the end. For those of you who are interested, you can remind me, and I will list a handful of conditions where we use an antibiotic for treatment when there is no fever. Okay. Now, this must have been covered by Dr. Asrani, but I will just revise that today. These are the organisms that cause upper respiratory tract infection, whether it's pharyngitis, tonsillitis, otitis media, sinusitis, bronchitis. Even many of the lower respiratory tract infections are caused by these organisms. Strep pyogenes, strep pneumoniae, H. influenzae, Moraxella catarrhalis, and Staphylococcus. If you list these 5 organisms, believe me, they will account for more than 99% of all the infections that you're going to see in your outpatient practice. Yes, very occasionally you have a chronic suppurative otitis media that is due to Pseudomonas. आमतौर से नहीं होता है. It doesn't happen in your practice. Don't think of that first. So for each of these 5 organisms, we have first choice antibiotic, which is what you should be using by and large. So for the first 2, we use amoxicillin alone, plain and simple amoxicillin. And for strep pyogenes, amoxicillin sensitivity is 100%. I know that nowadays in 10th standard, children even get 101% marks. So marks add hota hai for whatever sports and whatever backward class and whatever category. I would put amoxicillin sensitivity to strep pyogenes as 102%. So there is no strep pyogenes that will not respond to amoxicillin. So, and strep pyogenes will cause pharyngitis and tonsillitis in the vast majority of your patients. So once you see pharyngitis, which you think is bacterial, I'll come to that a little later, your drug has to be amoxicillin. There is no alternative. This column is blank. It has to be amoxicillin and only amoxicillin and only amoxicillin. For strep pneumonia, yes, we are getting a few cases of resistance. So these are your choices. Cephalosporins, which can be a first, second, or third generation one. Even the first generation sometimes work. A macrolide, which should be erythromycin or clarithromycin, and not azithromycin. These are the macrolides that work better for strep pneumonia, not azithromycin. For H. flu and Moraxella, most of them are beta-lactamase producers. So they will destroy amoxicillin. So you should use amoxiclav as your first choice. Cefuroxime and macrolide are your other choices. Staphylococcus, of course, we know cloxacillin or anti-staph penicillin is the drug of first choices. They are not easily available, but now we do have 1 or 2 companies that have recently come in the market with, I think it's not cloxacillin, I think it's flucloxacillin or dicloxacillin, but they are available now. But the other choice, if this is not available, is a first generation cephalosporin like cefotroxil. And alternatives, I'm only talking about oral here. Linezolid can be used in your practice only if you have documented MRSA on a culture, not otherwise. So having spoken about that, let's talk about the individual conditions. Okay, 2 children here. These are the appearances of the throat. One on the left, one on the right. I'm going to ask you which of these you think is bacterial, the one on the left or the one on the right. I don't think I would like to, I'd ask for your answers right now. It might be difficult. We are on a Zoom, but mentally think of your answer. And I'm going to display what the correct answer is and see if you are right or wrong. The one on the left is streptococcal And the one on the right is Epstein-Barr virus. So this is bacterial, this is viral. So what am I trying to tell you? What I'm trying to tell you is that what looks like a purulent exudate might actually be a membrane that you see in EBV, which is viral and therefore does not need an antibiotic. Whereas this is bacterial and therefore might need an antibiotic. So it's rather difficult to distinguish a bacterial from a viral pharyngotonsillitis. So what is the solution? So the solution is to look at the clinical background. Acute bacterial pharyngitis, which is almost always due to group A beta hemolytic streptococcus, which is the other name for strep pyogenes, which I just showed you on a slide, couple of slides earlier. The clinical history is very characteristic. Sudden sore throat, sudden onset sore throat, fever high, headache, nausea, vomiting, abdominal pain, marked inflammation, sometimes with a patchy discrete exudate, presence of anterior cervical lymph node, submandibular jugulo-digastric, that's where you should look. And they are tender. Just enlarged lymph node do not qualify. They have to be tender on touch. And of course, they are seasonal. They occur in crops, usually in winter or early spring in our country. And often there's a history of exposure to a colleague in the class or in the play group or wherever. On the other hand, if you see associated conjunctivitis, redness of the eyes, you see nasal discharge, the child is coughing or has got vomiting and loose motion, this is not bacterial, and therefore no antibiotic is indicated. But if you want to be really sure, we have the strep test, which is a simple strip that is available, which you just rub it as is shown in this picture here, slide 2. And now all of us know how to do this because we've been through COVID. Humko pata hai ye kaise karne ka. It's similar to that. You rub it on the back of the throat or the tonsils. And then there is a simple procedure. Within 15-20 minutes, you have an answer. And if it is positive, the antigen test is positive, then of course it means it's strep pyogenes and you can use amoxicillin. And as is shown again on this slide, amoxicillin susceptibility is 100%. Macrolide resistance is 2 to 20%. So there is absolutely no reason to use a macrolide. For a pharyngitis, pharyngotonsillitis, amoxicillin, amoxicillin, amoxicillin. Okay, but we have a scoring system for deciding on the need for antibiotic resistance, because you will say, have I to use this strip, which can be a little expensive. I think it costs around 500 or 600 rupees. It's available in only a few labs. How do I use this? Am I going to use it in every patient with a sore throat? The answer is no. You do a clinical scoring, which is called as a modified Centaur score. And there are the Centaur score is based on only the same 5 parameters that I described. Height of the fever, presence of cough, tender lymph node, and so on. You can look it up, but these are the same 5 parameters that are there, which are the Centaur scoring. If all the 5 parameters or 4 or more are present, then yes, you can start antibiotic even without doing the test. If the score is 0 or 1, that means only 1 or none of those parameters are present, no testing, no antibiotic. Whereas if you are in between, ideally, you should do the test, and if it's positive, you treat with antibiotic. If it's negative, you don't use antibiotics. Now, if this test is not available, or this test you don't want to perform because it's so expensive or whatever, what I would do, and that is my normal practice, is to wait for 3 or 4 days. Unless, of course, you have a child who's very sick and toxic looking, and that possibly means the streptococcus has now caused bacterium and spread to the rest of the body. But if you just have pharyngitis and tonsillitis, it's perfectly safe to wait for 3 or 4 days also. Why am I saying this? For 2 reasons. One is, if it's viral, most viral infections will start reducing on their own without antibiotic therapy within 3 or 4 days. If that does not happen, if the patient keeps getting worse, you're reasonably certain on clinical ground that this is a bacterial infection. Then you'll say, okay, but 4 din rukne ka? What about if the patient gets rheumatic fever? If he's in 6-year-old and you're worried that he's going to get rheumatic fever, then I can assure you that there is enough data that even if you start an anti-strep pyogenes antibiotic, after 1 week of getting pharyngotonsillitis, you will still prevent rheumatic fever as late as the 8th or the 9th day of infection. So it's perfectly safe to wait for 3 or 4 days, definitely. And you will often find that the patient is getting better, the fever is gone, and therefore you are certain that this does not need antibiotic. Okay. And if you have to use an antibiotic, what are your antibiotic choices? It's amoxicillin. Now, you can even use penicillin G, and of course, not easily available. I think only one brand is available, and it's called Pentits. I don't mind mentioning the brand because it's the only brand available. So you can use that, and you have to give it for 10 days. We know you have to give it for 10 days because you need to not just cure the patient, but you have to eradicate the bacteria because you want to prevent rheumatic fever. Of course, this is valid only if the child is in the rheumatic fever age group, which is 5 to 15 years of age. You can also use benzathine in a single dose intramuscular injection. This is useful in, we used to do this in KM hospital. Patient lamba rehta hai, cannot, amoxicillin is not available or is not tolerating amoxicillin. Cannot rely on the parents to make sure he's going to give it for 10 days. 3 दिन में बुखार जाता है तो दवा बंद करते हैं. You give one benzathine pencil intramuscularly, and you know that the antibiotic in the benzathine combination lasts up to 3 weeks. So then more than 10 days, so you're sure that you're going to prevent rheumatic fever. This also, I think, you know, is the drug we use for preventing recurrence of rheumatic fever once it has happened. The same thing, you can use it for initial treatment too. There is some data on shorter courses for cefpodoxime, but I don't believe we should use this. Amoxicillin for 10 days works fine enough. And you will need to use a macrolide only if there is allergy to penicillin. You can use erythromycin or clarithromycin, not azithromycin. And the other drug we can use is clindamycin. I see a lot of participants are raising their hands, but if you don't mind, I will take questions at the end because I don't want my flow to be disturbed. If you don't mind, I will take all your questions. In younger children, or if they are immunocompromised or they are very severely ill, you need to consider coverage for staph. So while strep is the commonest cause of bacterial tonsillopharyngitis, you can also have staph. Cru, of course, no antibiotic at all. Epiglottitis, very, very rare in this country. I've seen only 2 cases in 36 years. So most patients who present to you with brassy cough, little difficulty in breathing, and stridor are viral cru, not epiglottitis. And this typical pattern of nighttime onset in the winter season, or when there's a sudden breeze or coolness at night, barking cough, hoarse voice, benign looking throat is a viral cru, no antibiotic is needed. Epiglottitis is very rare. There's high fever, toxic look, the child is unable to swallow, so he drools. And a severely inflamed throat, and if you do a CBC, you find leukocytosis. Of course, there you're going to use amoxiclav. I showed you this is the drug of choice for H. influenzae. For otitis media, you should diagnose by doing only an otoscopy. Don't diagnose otitis media just because the child complains of ear pain. This is what a normal eardrum looks like on otoscopy, and this is what it looks like when you have an acute purulent otitis media. There's a vast difference. It's pretty easy to make out. I would strongly suspect that all of you should buy an otoscope and use it in your clinic. We know that otitis media, about a third of them are possibly viral, but difficult to distinguish viral from bacterial. So we generally tend to treat all acute otitis media as bacterial and treat with an antibiotic, but I'll come in the next slide as to conditions when you start the antibiotic. The organisms that cause otitis media are H. flu, moraxella, strep pneumonia, streptococcus. So your antibiotic choices are these: amoxicillin, amoxiclav. You've seen this in the previous list. इसमें कुछ नया नहीं है. But if you have to use a macrolide, only if you have a patient who is allergic to this group of antibiotic, what we call beta-lactam, then only you should use a macrolide, and you should use a clarithromycin. We don't prefer macrolides because they do not penetrate well into the middle ear fluid where they are required. Your organisms are there inside this pus. Your antibiotic is required there. So clarithromycin and most macrolides do not penetrate as well into the middle ear fluid as the beta-lactams. So always prefer beta-lactams. But when are you going to use an antibiotic? Not every patient you diagnose as acute otitis media after you have looked at the symptoms and a physical examination, including the otoscopy. Above 6 months of age, and I'm not going to talk about below 6 months of age because the recommendation is below 6 months of age, otitis media needs admission and parental antibiotics. So I'm only going to talk about above 6 months because I said I'm going to stick to only OPD treatment. Above 6 months, you will treat if there is otorrhea, that means there's a ear discharge, or severe signs and symptoms. What are severe acute otitis media? Moderate or severe ear pain lasting more than 48 hours, or a fever above 102.2 degrees Fahrenheit. If any of these are there, or at least 2 out of these 3 are there, it is severe, and therefore you will use an antibiotic for 10 days. Between 6 to 23 months, even if not severe, you will use if it is bilateral. If it is unilateral without severe symptoms, the recommendation is wait for 48 hours before starting antibiotic. And you will use nasal decongestants, steam inhalations, antipyretics, and call the patient back after 48 hours for re-examination. If the patient is better, the eardrum looks less red, the fever is gone, the pain is gone, there is no need to start an antibiotic. Above 2 years of age, without severe signs or symptoms, the recommendation is you can observe anyway, or you can use an antibiotic, but a shorter course is recommended in this age group. Now, these are recommendations. These are not a pediatrician's recommendation. Look at the reference. It's an American Family Physician Journal. So this is what's for you. It's not just for me. So this is what you should be following. These are the AAP, AAFP guideline, which is the American Academy of Pediatrics and the American Academy of Family Physicians guideline. So this is what we should be following. For sinusitis, which sometimes is associated with rhinitis, and therefore you use this term ABRS. What is ABRS? Acute bacterial rhinosinusitis or mastitis. And remember that sinusitis is uncommon below 5 years of age. The bacterial pathogens are basically the same as you see for acute otitis media, so I'm not going to repeat. However, in mastocytitis, staphylococcus is more common, but I'm not going to talk about mastocytitis because mastocytitis is not treated on OPD basis. They require admission. So therefore, the antibiotic choices are the same as for AOM. For mastocytitis, as I said, you need IV therapy, so I will not go into the details. But you need prolonged courses, same antibiotics, but minimum 2 weeks, not 10 days, not 7 days, sometimes 3 weeks. And sometimes you need to call your ENT surgeon to do a surgical drainage. Which patients of ABRS are you going to give antibiotics? How do you make a clinical diagnosis? Do you need an ENT surgeon? Do you need an X-ray? Do you need a, God forbid, a CT scan? No. This is the clinical diagnosis of ABRS. Persistent, not improving disease, more than 10 days. मतलब क्या है? Severe बीमारी नहीं है तो पहले 10 दिन में एंटीबायोटिक नहीं देने का. 10 days, not 2, 3, 4 days. Not patient saying, doctor 5 दिन हो गया बुखार अभी भी है, 5 दिन हो गया सर्दी नहीं गई. Sorry, this is not a diagnosis of sinusitis. These are the IDSA guidelines, the Infectious Disease Society of America. 10 days of persistent not improving disease is the clinical diagnosis of sinusitis. Or second option, severe symptoms, and I already described what is severe symptom, more than 39 degrees, 102.2 degrees Fahrenheit, and thick purulent nasal discharge. Both have to be there. Or facial pain over the sinusitis region, and that will depend on which sinus it is. It may be below your eyes, on your cheekbones if it is maxillary sinusitis. It may be on the frontal region if it is a frontal sinusitis. It can be deep in near your eye sockets if it's ethmoid sinusitis, and so on. Facial pain lasting for 3 to 4 consecutive days. Pretty stringent requirement to make a clinical diagnosis of bacterial sinusitis. And the third is worsening symptoms or double sickening. What do you mean by this? You have a patient who comes to you with a URI, looks like a rhinitis to start with. पहले 3-4 दिन बुखार रहता है, then he starts getting better. 3-4 days his looks seem to be getting better, and then he starts again with symptoms and fever again. This is double sickening. कि पहले ठीक था, पहले he was sick, then he got better, and now he become doubly sick. This is what you mean by double sickening. When you see this is usually a secondary bacterial infection in what started as a viral infection, and that usually is bacterial, and therefore you are allowed to use an antibiotic. So next time, think before you start antibiotic for a clinical diagnosis of sinusitis, unless he has severe symptoms, which I already described, or more than 10 days have passed, not before that. Okay, I'm going to come to the next topic, which is GI infection. Look at this child, 8-month-old female girl child, weight 8 kilos, loose stools for 2 days, watery, greenish yellow, fever is 101, vomited twice, dehydration hai, stool examination showing pus cells 5 to 6, RBC is 2 to 3. Which antibiotic to give? I'm going to pause for 10 seconds. Please make an answer mentally. This is not a test. This is not an examination. We are all here to learn. So keep your answer to yourself, but be honest and see what your answer, whether it tallies with what I'm going to tell you. First of all, my answer is antimicrobials are not justified. Presence of few WBC and RBC in the stool does not indicate an invasive infection. Antibiotics are recommended only for invasive infection. Most likely this is a viral infection, maybe rotavirus, maybe some other virus. You get norvovirus, Norwalk virus, you can get even adenovirus causing diarrhea. And nowadays, of course, you have this fancy stool test that can identify some of these viruses, what is called as biofires. Mat karo yaar, 10,000 rupiya lagta hai usko. But it can also be a bacterial infection like enterotoxigenic E. coli, where the diarrhea is due to the toxin. It is not invading the mucosa. And therefore, these are self-limiting. They will not be benefited by antibiotic. A dysentery, which is usually caused by Shigella or sometimes Salmonella, will show visible blood in the stool. Visible means visible to your naked eye, not a lab report saying 2 to 3 RBCs per eye per feet. 2 to 3 RBCs kya hota hai? Nothing. That's not dysentery. Dysentery is visible blood in the stool. So in this patient, the case I described earlier, and I can go back to that slide so you can revise. This patient, who you often see in your clinic, does not require antibiotics. What it requires is ORS, zinc, and continued nutritional support. So when do you give antimicrobials in diarrhea? When there is visible blood in the stool, because this is a dysentery. When you have documented amoebiasis or giardiasis. Again, these are not antibiotics. I mean, they're antimicrobials, but we do use metronidazole for them, which can be considered as an antibiotic because it also works for certain anaerobic bacteria. So that's why I'm including it here. Cholera, and in today's paper, I read that there's a cholera starting in the Amravati district. We don't see it in Bombay, haven't seen for the last 10 years. Diarrhea, which is associated with a systemic symptom. You see this in small infants, you're not going to see it in your OPD. We call this parenteral diarrhea. A newborn with sepsis can come with diarrhea when actually his blood culture is positive. I've seen a 2-month-old presenting with diarrhea and vomiting and actually has a pyogenic meningitis. वो आपके काम की नहीं है. These are what pediatricians deal with. And of course, if your child is immunocompromised, and that includes a severe PM or marasmic kwashiorkor patient, then even without these being there, you are allowed to use an antibiotic. Which antibiotic will you use for a bloody diarrhea? The WHO recommends ciproflox, norfloxacin, but you know these are not recommended by our drug controller general for pediatrics. So we would use the second line, cefixime, azithromycin, codromax. So these are my only 3 choices, and I generally stick to cefixime. Antibiotics that are not to be used for bloody diarrhea are furazolidone, first and second generation cephalosporin. They don't work for gram negatives. Aminoglycosides. How often I see patients getting an intramuscular dose of a gentamicin or amikacin for diarrhea, and I'm ashamed to say that even pediatricians do this. I'm not really talking to you, my family physician friends. I hope even some pediatricians are listening to me because some of them are also making the same mistake. And cholesterol sulfate, better known by a very popular brand name, which I won't even take, doesn't work. Neither do sulfa drugs. Do we need to use metronidazole? No. Amoebiasis is uncommon in young children. Less than 2% of acute childhood diarrhea in children below 5 years of age is due to amoebiasis. So when would you use amoeba, anti-amoebic agent like metronidazole? Because we know that it's very difficult to show amoeba in the stool. It requires a warm sample to be collected immediately, sent to the lab in warm condition without cooling, and examined within 15 to 20 minutes so that the person can see under the light microscope the motile trophozoite. ये कहाँ होता है भाई? Individual hospital में भी नहीं होता. I'm telling you very frankly, this is not easy to do. And therefore, when do we make a diagnosis of amoebiasis again in an older child above 5 years? When two different antibiotics that are usually effective for a Shigella given sequentially fail. That is, the patient comes with blood and mucus in the stool. आपने पहले एक दवा दी, maybe cefixime, didn't respond. You gave azithromycin, didn't respond. Then maybe you are justified in thinking that this might be amoebiasis. Or the second option, which I said, is only in our dreams that we are going to see this. Coming to skin and soft tissue infection, which we commonly call pyoderma, again a bad term, because again pyoderma like URTI is a very general term. Skin and soft tissue infection is a heterogeneous group of conditions. We need to identify the layer of the skin or subcutaneous tissue that is involved. And the treatment is accordingly different. What are the organisms that cause skin soft tissue infections? Again, these two friends of ours, not friends, they are enemies. Staph aureus and Strep pyogenes are the ones that we see. And remember, when you see skin and soft tissue infection, you also need to consider whether local antibiotic treatment applied on the skin may be adequate, but sometimes you need to combine with systemic therapy. So, what are the different skin and soft tissue infections? They are labeled here. Impetigo is infection of the superficial outermost layer of the skin. Erysipelas is infection of the lymphatics. Folliculitis, furuncles or carbuncles is involvement of the hair follicles and the surrounding tissue. Cellulitis is when the subcutaneous tissue is involved. Sometimes this forms an abscess, which we call forms an abscess. And when the lower levels, including the fascia, are involved, we call it necrotizing fasciitis. Now, of course, necrotizing fasciitis is dealt with in inpatient, so I will not talk about that more. But let's talk about these first 3 or 4 conditions. Important thing to remember is that lymphatics occur at this level, anatomically speaking, and blood vessels are at this level. Why is this important for us? It is important that when you have impetigo, that means you have infection of this portion of your skin, an orally given antibiotic or injectable antibiotic is not going to work well because it's not going to go beyond this level. So therefore, the dictum is if you have impetigo, probably simply an oral application will do. Whereas when the lower levels are involved, you're going to need a parenteral or an oral antibiotic. That is very simple. Once you look at this diagram, you will know very simply. Now the next question comes in your mind. अरे यार कैसे बोलने का कि impetigo है, folliculitis है. Dr. Prabhu has shown a nice cut section. Are we going to do skin biopsies and see where the level of the infection is? The answer is no. The answer is simply look at the patient. The diagnosis of various pyoderma is by their appearance. And therefore, the diagnosis is almost entirely clinical. You don't need any section. You don't need any biopsy. You don't even need any blood test. You don't need any imaging. This is what impetigo looks like. You get these honey-crusted lesions, typically on the face, around the neck, and the shoulders are common sites in children. This we refer to as impetigo contagiosa. Sometimes in other parts of the body, you see bullous lesions like this, with you can see blisters with pus collection in that. This is referred to as bullous impetigo. And when they rupture, they can lead to this kind of lesions. Clinical diagnosis, impetigo, local treatment, unless the patient has got fever or something, which indicates that these organisms might have caused bacterium and spread elsewhere. So treatment of impetigo is local treatment. Mupirocin is the drug of choice. These are the other agents that you can use, but I stick to mupirocin. I don't see why I should use this unless I say a patient who does not respond to mupirocin. The only problem with mupirocin is that it's a little more expensive than the other agents which are listed here. Mupirocin has the advantage that you can use it only twice a day. The other ones you need to use more often, 2 to 5 times a day. अरे कौन से मदर को याद रहता है दिन में 5 टाइम एंटीबायोटिक लगाने का बच्चे के चमड़ी पे? नहीं होता है. So use mupirocin. Systemic antibiotics only if there's bullous impetigo which has ruptured, because then it means the organisms have now gained access to the bloodstream, or if it is in many parts of the body, or it is in the perioral region, that means around the mouth. The reason why we like to give oral antibiotics for perioral region is that this is what, if you remember your Love and Bailey, is surgical textbook in our undergraduate days. These are what we call this is what is called the dangerous area of the face. There are penetrating veins here which communicate with the intracranial veins or the sinuses, and therefore the infection can spread to the intracranial cavity. So these are the indications for systemic antibiotic. This is what erysipelas looks like. Infection of lymphatics, it spreads in a centripetal manner like this in the direction of flow of the. These are painful erythematous lesions that require systemic antibiotics, whether oral or parenteral. Deeper infections are furuncle. You see this, it's easily well recognizable. It's in the hair follicle, painful red swelling, warmth and tenderness is present. This is cellulitis, you must have seen several cases. Sometimes you see these bullae rupture and then there is an actual discharge of purulent material. This is what an abscess looks like. Warm, tender, fluctuant, and sometimes if it has ruptured, you see discharge. You can see the pus there. So this requires systemic antibiotics. Many of these patients will have systemic symptoms. They will have fever, may have anorexia, they may have body ache. Usually a sign that the bacteria are in your patient's bloodstream and likely to go in other parts of the body. And obviously, without an open wound, your local antibiotics are not going to penetrate to the lower levels. Remember, where is this level? I showed you the picture earlier. This is the lower levels of the skin. So, a locally acting antibiotic is not going to work. So how do you treat this infection? Moist heat application is helpful. It helps the abscess or the furuncle to rupture. If it's a large abscess, it must be incised and drained. You can pluck the affected hair for a furuncle that affects the drainage. Antibiotic treatment is required. Systemic antibiotics are required, whether oral or parenteral. What will you use? Those that cover strep or staph. My first choice is the first generation cephalosporin. Coamoxiclav may be used. It covers a lot of staph as well as strep, of course. If there's systemic toxicity, you're going to use injectable. Local antibiotic creams may be additionally used. Additionally, don't use them alone. If there is a wound, then you can apply, because then it will penetrate into subcutaneous tissue. Coming to UTI, common in children, especially girls. The symptoms are difficult to elicit in younger children, so we often miss it unless we do a routine urine examination. If a routine urine shows pyuria with a positive leukocyte and or nitrate test, and many of the labs will show you this, you even have these strips that you can do it in your own clinic. It's highly suggestive. Of course, confirmation by culture is desirable, but may not be always positive. And you need to start an antibiotic if you see this diagnosis without waiting for a culture report. Because in a younger child, early treatment of UTI is important to prevent renal scarring, which can lead to kidney damage and end-stage renal disease. What are the antibiotic choices? Cefixime, cotrimoxazole, amoxicillin or coamoxiclav is often effective. So sometimes you start because the patient, start one of these because the patient seems to have maybe a little bit of a running nose or gala thoda lal dikhta hai, you think it might be a URI. But for just to be sure, you want to get a urine done. So you start the patient on amoxicillin. And after 2 days, the patient comes back with the urine report which shows UTI. But the mother says, "Arey, patient ka bukhar chala gaya." So amoxicillin or amoxicillin can often be effective, and you need not change to the first two if the patient is better. You can use the fluoroquinolone, not my choice, because the DCGI does not permit it. And we often see a resistance now. We see a lot of fluoroquinolone resistance, so I would not like to use this. These antibiotics are not suitable for UTI in children. Nitrofurantoin often used in adults, but it is not suitable for children because nitrofurantoin works only for cystitis, not for pyelonephritis. And many children have an upper UTI, not just a cystitis. And therefore, they need an antibiotic other than nitrofurantoin. The other problem with nitrofurantoin is a QID dosing, which is difficult to do in a small child, especially when a syrup is not available and it's exceedingly nauseating to take. So I don't use nitrofurantoin very rarely, not for treatment. You can use it for prophylaxis. Chloramphenicol, azithromycin are not suitable because they're not excreted in the urine to a large extent. Finally, coming to enteric fever. Now, you can start clinical treatment for empiric fever after sending a blood culture or other tests. I'm not going to talk about diagnosis here. If your clinical features are highly suggestive, what are they? In an endemic zone with history of exposure, a patient बम्बई में है, बारिश का सीजन है, चौपाटी पे जाके भेलपुरी खाया, उसके साथ 2 लोग थे, उनको भी टाइफाइड हुआ है. I think I have enough evidence that this child with fever is likely to be typhoid. Clinical pictures, stepladder pattern of fever, marked anorexia, headache at the back or back of the neck, toxicity, coated tongue. You know all this. I've discussed this in my earlier talk on how to diagnose clinical fever, a clinical typhoid. You can treat with oral antibiotics if you find early and the patient is non-toxic and there is no vomiting. What antibiotic you'll use? Cefixime is the drug of choice. You can also use cotrimoxazole. These are the doses and duration. Azithromycin is not the first choice. Please don't use it. We are seeing 15 to 20% resistance to this antibiotic for typhoid fever. And my problems with ofloxacin and ciprofloxacin, I already said I don't use them at all. However, when you're starting oral treatment, watch for complications and don't hesitate to switch to injectable if there is worsening or vomiting. So, finally, let me come to rational antibiotic usage itself. What do we need to remember when we use antibiotics? We need a newer approach. We need a dual focus. We have to stop thinking that my patient should have a good clinical outcome. We also need to think that we need to use antibiotics optimally. This is a term we call antimicrobial stewardship. And you hear this term next Thursday in many times because Dr. Soman, who's going to speak, is a fan of this. And I think it's a very important to be a fan of this term and do it. Stewardship is a term we rarely use when we speak about other drugs. We never talk about antihypertensive steroid. We don't talk about anti-diabetic drug stewardship. No analgesic stewardship. Why do we talk about antimicrobial stewardship? Because antibiotics are a different class of drugs compared to others. If you compare antibiotics with other drugs, antibiotics efficacy wanes over time. What was working today doesn't work 10 years from now, which is why, as I told you, pharma doesn't want to make new antibiotics. वो अभी चलता है 10 दिन के बाद कोई काम की नहीं है. Other drugs continue to be effective today. Use an antihypertensive drugs in 1970, it works as well today. You cannot say the same for a ciprofloxacin. Antibiotics disturb the gut microbiome and the friendly flora that we have, which is not a problem with other drugs. And we also know, I showed you earlier, how resistance in one patient can be transferred to another organism from one bacteria to another by various mechanisms. So therefore, misuse in one patient can harm many others. So this trouble that you may do in one patient can cause problems in a large number of patients in the community, which does not happen. If you use an antihypertensive incorrectly for one patient, your patient will get hypotension. Baki kisko kabhi problem nahi hoga. But that's not the situation with antibiotics. So therefore, we need to do antimicrobial stewardship. What should all of us do individually and say that we are doing antimicrobial stewardship? We all need to use antibiotics rationally in our practice. I've told you how, at least for the 5 common conditions. But more important, we need to announce publicly that we are doing so. Sabko batana hai ki hum kar rahe hain is as important as doing it. What do I mean by that? We need to demonstrate a commitment to antimicrobial stewardship. So I would strongly suggest that you put such a poster in your clinic. Ye ek example hai, which is a US example. You don't need such a poster. You can just put your own photograph in that and write, type out or print a poster from your computer saying that I am committed to responsible antibiotic prescribing. क्या होगा इससे? क्या होता है? एक तो patient or the parent, I'm saying parent because I'm a pediatrician, but the patient who पढ़ता है ना, he will think there is something different about antibiotic. We have to use it responsibly. If he wants, he's tempted to use it next time on his own or get it from the chemist, he will think twice. And more important, it has been shown by a study, which is quoted here at the bottom, which was published in JAMA, कोई ऐसा वैसा नहीं, actual study, कि any doctor who has put such a poster in his clinic in which he has put his photograph and signature prescribes antibiotics less by a factor of 20%. अपने आप, because he is conscious कि मैंने बाहर लिखा है. I have said I'm going to use it. I have to think twice before I use it just like that. And we also need to educate the patients that antibiotics won't speed up cold and recovery. You hear the story. अरे इसका exam है Monday को, इसलिए antibiotic दे दो जल्दी ठीक होगा. That doesn't happen. Viruses are not cured faster by antibiotics. They don't speed up cold and flu recovery because they are viral infections. We can put up such posters. We can simply write it that don't use leftover antibiotics. Most common infections are viral, particularly colds, coughs, urine, diarrhea. Antibiotics do not work against these infections. ये ज्ञान बटाओ ना सब, बढ़ाओ. Put it in your clinic. Put a big poster outside. I know all of you have big practices and your patients wait half an hour to see you. Let them read this every time they come and sit. Let them imbibe this message. We need to all follow good antibiotic prescribing practices. We need to have a limited selection of antibiotics that you're going to use empirically. And these are only 5. I've listed them in today's talk. इसके आगे आप इस्तेमाल नहीं करेंगे unless you have a culture report saying that the other 5 are not working. Should I repeat this statement? It's the most important statement. Prescribe only 5 antibiotics for pediatric patients in the outpatient. Amoxicillin, amoxiclav, a first generation cephalosporin like cephalexin or cephadroxil, a cotrimoxazole, and cefixime. इसके आगे आपको नहीं लिखना. Can I be more definitive about this? Believe me, I don't write more than this 5. And my patients have not died. They have not gone to another doctor. They recover. This is all you need, 5 only. When you use an antibiotic, use them in the correct doses based on the body weight. Write the complete duration. 10 दिन यानी 10 दिन. You can't write 7 days. I told you where you use 10 days, otitis media. Write down a clear and simplified dosing regimen that the patient understands thoroughly. Don't write short form like BD into 5. किसको समझेगा यार? After breakfast, after dinner, every day for 5 days. This is what you should write. You need to pay attention to the drug formulation, the dosing schedules, interaction with other drugs, food, खाने से पहले लेना है, बाद में लेना है. All this has to come in your prescription. And make sure that your patient takes it. Ensure compliance. When he comes to you again after 2 days, ask him, has he taken? If possible, ask him to bring the strip and show you that the strip is completed or the bottle is over or whatever. Judging by that, you know whether he has taken the correct dose or not. We also need to practice good antibiotic sparing practices. Don't use prophylactic antibiotics. Left and right say, I know this is viral yaar, but उसको कल bacterial pneumonia नहीं होने चाहिए, इसलिए आज सर्दी के लिए मैं दे दूंगा. Not valid. We need to advise patients on hygiene and sanitation. Keep everything clean. You'll get less infections. Don't eat unhygienic food. Wash your hands and feet after a wound in running water, and so on. Use antiseptics rather than antibiotics wherever possible. I have mothers who come and ask me, एक सॉफ्रामाइसिन घर पे रखेगा तो चलेगा क्या? बच्चे को थोड़ा खेलने के टाइम लगता है. So should I apply that? The answer is no. Use an antiseptic. Use Dettol. Use mercurochrome. Use betadine. Don't use an antibiotic. And in fact, many surgeons nowadays still prefer betadine even for operative wounds, for the umbilical stump after discharge. So no antibiotics here. And encourage immunization. Please give vaccines. And that's why we are seeing that while antibiotic numbers have gone down in the last 2 decades, the number of vaccines are going up because you don't see this resistance to vaccines like we see resistance to antibiotics. Obviously, bacterial vaccines are going to help because bacterial infection nahi hoga because of direct protection from the vaccine. There is no need for antibiotics. But we also know that certain vaccines prevent colonization. They inhibit the carriage of organisms on the skin or in the throat. This reduces the transmission of these pathogenic bacteria to other members or other children. And these people may be even unvaccinated. So they are protected even though they're not vaccinated. This is a term we call herd immunity. Viral vaccines also help in reducing antibiotic usage. How? Because less fevers, less antibiotics are inappropriately used. Somebody has said a very important quote. The highest risk of antibiotic usage is when you get a fever. Because you'll go to a doctor and some doctor or other is going to give you an antibiotic inappropriately when it's viral. So if you don't get viral infection, you're not going to go to a doctor. If you're not going to go to a doctor, you're not going to get an antibiotic. So if you can prevent influenza, the patient will not get flu, so he will not get cough and cold. So he will not go to some doctor who will give him an antibiotic inappropriately. And also, we know that many viral infection, secondary bacterial infection hota hai. So if you don't get the viral infection in the first place, you're not going to get secondary bacterial infections. So I want to end by a couple of slides. So I hope I've impressed you on the urgency of practicing rational antibiotic practice, the urgency of doing so. But knowing is not enough. We have to apply right from tomorrow. Being willing is not enough. We must actually do it. This is what Leonardo da Vinci said 700 years ago. And I know this is somebody who said it more recently. John F. Kennedy, a man I highly admire. He said each man can make a difference and every man must try. Because आपके दिमाग में अरे वो पड़ोस वाला लिखता है, वो धारावी में जो है that fellow who's a quack, he writes antibiotics. What क्या फर्क पड़ेगा मैं लिखूं या नहीं लिखूं? Believe me, each man can make a difference, but every man must try. Thank you. And now I can take questions.
Dr. Suhas, thank you very much. And you know, I am always called little crazy. So now with your suggestion, I promise to my audience, we will give you an email ID. You send us your photograph and full name. And within a week, we will send you a color poster, which you print in color, put your signature and display in the clinic. We'll do it free of cost for you, because I think we have to start a movement. And you start from your own family. You know, as doctors, we don't examine our family members at all. We just empirically give medicine, never give antibiotics.
I have a better suggestion, Chandu, if you don't mind.
Yeah, bolo. No,
I think every person should have his own photograph in the clinic. उसके ऊपर दबाव ज्यादा आता है कि हमने खुद मेरा फोटो लगा के लिखा है कि मैं एंटीबायोटिक नहीं दूंगा.
I am telling them, send me your picture. I will create a poster.
Okay. You will create for them. Yeah, fine. I thought he said telling me to send my photo. No. Okay, fine.
No, not yours.
Great.
Each doctor has to send me a photograph, his proper name, and I will create a poster for them. They get a color printout, laminated and put it.
Correct. Excellent. If there are any questions, I can take them now. I see a lot of comments, but not many questions. But if there is some time, we can still take questions.
You have covered everything so well. Questions are all in the mind. I think more than questions, no. There must be a lot of guilt. If we are honest, there will be a lot of
My
guilt.
aim was not to give guilt to anybody. My aim is we all make mistakes, including me. We all have to say that we are going to do better tomorrow. इतनी विनंती है और कुछ नहीं.
You want to hear some comments? That was the most passionate talk. Thank you very much. Wonderful presentation, excellent presentation, important teaching, excellent presentation. Thanks, sir. We'll follow your dictum. Excellent talk, excellent session. Thank you very much. So I think by now you are used to hearing excellent. What I will require now from you is the brand name of that streptococcal RADT.
I don't remember the brand name, but the lab will know.
Is it available in India?
In the lab. You can do it on your own, but most people don't do it because it's got a short half-life, shelf life. So
No,
आप लाके रखेंगे तो आपका
is it available in India? Is it available in India?
Yes. Many labs are doing it. Not all labs are doing it. But once you tell your pathologist or your local fellow कि मैं भेजने वाला हूं, आप लाके रखो तो लाके रखेगा.
ठीक है. Amazing, excellent, passionate session, amazing session, excellent session. Okay, one question. Dr. Deepa Sanghi, in enteric fever, is there any role for double oral antibiotic? I have seen prescriptions of the same.
One word answer, no.
No, good. Once antibiotic used, saved on memory should be used after 6 months. Is it true?
I don't believe an antibiotic should be left over. Saved on memory means what? I didn't follow that. What is saved on memory?
Sir, should antibiotics be given on empty stomach or after meals?
That depends on the antibiotic. Certain antibiotics are better absorbed on empty stomach. And we all know INH rifampicin in empty stomach. Sabko pata hai. But even penicillins, for example, are better absorbed on empty stomach.
Yeah.
Some penicillins are
oral
destroyed by
penicillin on
acid.
empty stomach. Yeah.
So you need to know the pharmacology of every antibiotic and then decide. Some are to be given after food. For example, antifungals are better absorbed in fatty meal. So take a fatty meal and then say maybe a pat of butter and then take say itraconazole or ketoconazole. They don't get absorbed on empty stomach. So it depends on the antibiotic.
Roxithromycin can be used as an alternate macrolide.
It is a very inferior potency compared to even erythromycin. So I don't use it.
Even if it is bacterial infection, can we wait for natural immunity to cure it if general vitals of the patient are good? Dr. Sneha Shende.
100%, I would agree with that. This is not to say that every patient before antibiotics were discovered died from every infection. ये बात तो नहीं है ना. Before 1928, everybody with sore throat died. No, they recovered. So particularly if you are having a healthy child, an older child, I won't try this experiment with a 6-month-old child. 7-8 साल का बच्चा है, healthy है, not looking very sick. It's perfectly okay to wait for a couple of days for treating with an antibiotic. But remember, for example, typhoid is not a disease where I would say no antibiotic. We know that typhoid complication mortality is there. Although patients with typhoid will get cured, majority of them even without antibiotic.
During internship days, I have seen so many nalidixic acid metronidazole prescription. Is it still used that extensively?
It is available, but it should not be used.
Should not be used. Which antibiotic should be started in UTI while culture report is awaited?
I gave the list. My choice would be cotrimoxazole or cefixime to start with.
Okay. For how many days antibiotic is recommended in indicated conditions?
I think they were all there on the slide. For each condition, I put the duration.
Friends, this video will be available on YouTube for you to watch repeatedly. Sir, I know some pharma companies are paying doctors to give more and more antibiotics. I will just say you don't be one of them. You can't correct everybody.
Correct.
About mouth-foot disease, that is a viral disease. No, so
it's
no,
viral. No antibiotics are required.
No antibiotic. Suhas, let's cut the cake.
Yeah, sure.
Purnima
I'll
is
put it
around.
in front now. I hope all of you can see it.
Purnima
I
is
would like
around.
to cut it with everybody watching. मैं कैंडल बाजू में रखूंगा यार. कैंडल किस लिए चाहिए?
I don't know. प्रीति ने कैंडल भेजा है कि नहीं भेजा है?
कैंडल है उसके साथ.
Okay.
But first of all, I'll open it and I will show it to the audience. And congratulations again, Chandu, for your 100th. There. This is the cake. Lovely cake.
Thank you. That is Preeti's choice.
It's very nice. It's a chocolate cake with looks like nice icing on it. So I'm going to cut it. I'll hold it up so people can see it when I cut. Congratulations, Chandu, again. And may 100 become 200 and 300. And thank you again for inviting me.
When I started the webinar in COVID, I did not think I will continue for long, but the response that we have got even today, I think we will continue as long as God gives us strength.
Thank you, Chandu.
And you know, support of stalwarts like you also motivates us.
Thanks, Chandu. God bless Inches and IDG.
Thank you.
Of course. Thank you.
So friends, we'll give you an email ID on which you send your good quality photograph and we'll create a poster for you and send it to you. Spend 50 rupees for a color printout and laminate it and put it in your clinic. Let's start a movement now.
Thank you. Thank you all.
Thank you.
I'll take your
Thank
leave.
you very much. Participants, bye.
Bye.